My presentation will be on the strengths and challenges of mental health care in Spain. It's based on my experience working as a head of a psychiatric department in downtown Madrid, and also as chairman of psychiatry at the our university, and head of our collaborative center, which is dedicated to mental health service research. What I'm going to cover today is these three aspects. I will do a very brief introduction to mental health care within the National Health Service in Spain, and then I will devote most of my time to talk about the strengths and the challenges that, from my point of view, we have in front of us on the organization of mental health here in Spain. The current National Health Service really started to have its current form in 1986, where law was passed that guaranteed that there was universal access to health care that funded by general taxation and subject to national laws governing legal entitlements. Most healthcare services are free at the point of use, and the system was based and organized around the catchment areas. National healthcare law of 86. That was the first time that the mental health care system, before it was not part of the national health system. It was located, introduced, and guaranteed the minimum set of services, mental health services, within the national health service. The 86 regulation also incorporated things that were happening in most European countries before, which was the institutionalization. There was not closure of the long-term hospitals, but there was an effort to reduce the number of individuals that were in long-term care facilities. And then, of course, there was the creation of general hospital psychiatric units, like the one I have where I work in the hospital, which was the centers for the acute patients of care of patients. And then, of course, the organization of the community mental health centers that will be based for all the outpatient care within the catchment area. A very important thing was that the primary care center, primary care physician, was the gatekeeper for specialized care, and that was also the case for psychiatric care, with a direct referral only for primary care centers to psychiatrists and also to clinical psychologists. And of course, the need for development of intermediate community services, the hospitals, the centers, and then introduce the need for a coordination with social services. So essentially, that was regulation in 86, that it's still the framework of the developments that we have now. What are the strengths of this system and how this has evolved? What are the advantages for the organization of the services that I see from my point of view? First of all, it is a universal healthcare system that shows that all systems have coverage in primary care, which of course is where most of the patients are identified. Many of them receive care there, and some of them are referred to specialist care. Currently, 99.5% of the residents of our country are covered by the National Health Services, which is extremely important, including minorities and most of the immigrant population. And the Ministry of Health is in charge of the national regulation, the coordination of the regional services, negotiation of the prices of drugs and also the medical devices at the central level, of course, reporting on several indicators. And then another thing that I will highlight is especially training and certification. So this is all done at the central level. And then as one of the outputs of this regulation at the central level, we have national strategies on several aspects. One of them is mental health. The first one is 2007, and there has been covering different periods of time, and we have one that was approved recently by the current government. They essentially establish a mental health care system that, as mentioned before, the gatekeeper is the primary care. It is based on the development of community mental health services. And then from these community mental health services, the patients can be referred to acute units, daycare hospitals, and in some cases, long-term care units, which are in a very reduced number, but still there. And then, of course, development of specialty units that are still there and that have a very unequal distribution across regions and catchment areas. And then, of course, the need to integrate and coordinate the care with all the resources depending from the social care services that are absolutely instrumental in the care of the serious mentally ill. Then another. So these are the minimal sets of services that all the catchment areas should have. So that guarantees a minimal set of provision of services covering all the ranges of ages and both inpatients and outpatient care. Another very strong point, which is the specialist training, and then also the specialist certification. This is done at the central level, and the Ministry of Health is the one in charge of regulating the training, and just 2 years ago a new regulation was established that the training for psychiatrists, which used to be 4 years, is now 5 years, and also the training for child and adolescent psychiatrists was also introduced also for 5 years. And it is at the central level that all this training is and the content of this training, the format of this training is regulated and supervised, and then the accreditation of the training units are done also at the central level. But it is also the case for clinical psychologists, which is also regulated at the central level training, and the same for nursing, mental health nursing. So that guarantees a level of training that ensures the quality, and also introduce a quality system for the recognition of those professionals coming from overseas, not from Europe. Said Europe, the European Union countries, where there is a need for a recognition of those accreditation at the central level. And that's why 77 and that guarantees the quality of our mental health specialized professionals. This that was culminated in 2002, where the um, management, the budget management, the organization, the coordination, the direction of the coordination, but actually the budget has been transferred at the local regional level, and within the regional level there is a distribution. That means that of course they need to follow the model of care that I referred before, but services that are being chosen and funded by the regional level, and that gives us a huge variety of services and innovation within these services that occur at the very general view of what are the strengths of this system that has some elements at the central level, but also it gives room for the local adaptation, regulation, and in the introduction on new services at the regional level. And then what are the challenges? What I do in my work, and from I see talking with other colleagues with some responsibilities in managing mental health service in general for health, and very low. Here we have the last estimates in dollars compared to countries for our region and Europe, but which is also very low. And this is the healthcare spending, which is very important for mental health. But we only look at the mental health care spending, which is difficult to really have to come with a figure. We take into account the burden of mental disorders, and also with the chronicity of many of the mental disorders that we take care of. And this is something very important we have is there's always the demand for care, which in this public mental health system, which are free of care. And what happens is that we really increase exponentially, or at least not exponentially, but at least in our estimates, about, for example, 25% on patients with depression after the COVID pandemic, and we are in the demand of our services. And to give you two examples of the current situation, we have seen something that was unexpected on adolescents, for example. Here's an example and of severe problems. And we have noticed that there is an increase on the number of general trend of the reduction for mental health problems, which is in contrast with the general trend of the reduction of hospitalization on this age range. And another signal of related sick leave since 2018. So that means that we have health systems that are, in many cases, which also mean that there's a delay on the care of severe mental health patients that are also that have to suffer this the number of psychiatrists. I mentioned before that we have a good process for the training, a good process for maintaining the quality of our training, trainees, and also our program. Health professionals as are needed, uh, even in the case that we have budget to hire them. We are still. This is something that we are seeing in the last 4 or 5 years. Case for major cities like the one I work, but also for other not so large cities and rural countries. And therefore, what we have Catalonia on the Basque Country, which have 3 times more psychiatrists than other regions of Spain. And this is something that it is very difficult to overcome because, as mentioned, we don't have enough professionals needed to create in the short term. Then another challenge that we have. These are the comparative statistics for suicide. Suicide in Spain is that's figure. That's a way to look at the problem, but really the proper way to look at the problem is not to compare whether or not it's higher than other countries in Europe, but whether or not we are making an impact. The way that we have to look at the problem, if there is any change on the trends, and as you can see, while in the globally, we can say that the number of suicide significant increase, not statistically significant increase, but what is relevant is that we haven't been able to reduce it despite all the development of services, despite all the programs, despite all the emphasis. And this is we need to be able to reduce. Maybe we cannot be happy with non-significant increases on suicide. We need to make an effort to reduce it because we have been able. There was a campaign between the 2000 2015 to reduce aggressively the number of deaths because of traffic accidents and because of HIV/AIDS, and it was extremely successful. While at the same time, we were not successful in reducing the number of suicide. What's one of the problems? One, from my point of view, because there was a lack of a national health strategy to reduce the suicide, and this is something that has just been approved for the first time. Spain has a national prevention strategy, and this is something that we were lobbying for years from our society and many others to as a requisite in order to confront this problem. Other challenges, of course, as many other countries in Europe, immigration, sustainability of the system, inequalities, all these regional variation makes that services that are accessible for some patients in some regions are non-accessible in others, and that creates inequalities. The problem of reinstitutionalization, of course, social inclusion is spending. Spain is one of the countries where the percentage of patients with severe mental disorders are work is lower. This is something that needs to be addressed. And then, of course, last but not least, right-based services. And of course, there's a movement in Spain, as many other countries in Europe, to base the care services on rights of the users. But of course, in the development of these rights services, we need professionals. We need the development of services. We need changes on the structure of our institutions. We need to incorporate more professionals, not only medical and psychology, clinical psychologists, in order to be able to address the issues related to involuntary measures. And this is something that we can do now because of budgetary constraint, because of changes. Some of course, there are some difficult to change the mentality of the professionals, but it's also very, very difficult to change the institution. And then, of course, another pending issue in the organization of mental health care is prevention. I mean, all the things I mentioned before was the development of services for patients, but we know that in order to address the challenges of the mental health problems, there should be an emphasis on prevention, and that prevention in several now in psychiatry as a room, and there are interventions that should be needed at the individual, but particularly at the societal level, in schools, in the workplace. And this is something that we are still far in our country. There are some experiences, but we need to have a focus and expand these interventions at this level.